Welcome, friends. Thank you very much for watching my video. Welcome to the medical student channel for surgical education mainly. Today I chose an important topic for you, and it is gallbladder cancer. Fortunately, the disease is rare. And I give you a historical background about the problem. Now, what you see in the photo there is Alfred Blalock, a giant figure in surgery in terms of history, who invented and devised a variety of surgical procedures in general surgery, vascular surgery, and other subspecialties. And there's a quote from him in 1924. And that's what he said. In malignancy of the gallbladder, when the diagnosis can be made without exploration, no operation should be performed, and as much as it only shortens patient's life. Well, we have come a long way since then in terms of inventing new treatment methods and variety of surgical and medical issues. That's the invention of antibiotics, intensive care unit radiology, chemotherapy, interventional radiology, and variety of other modifications of treatment. The unfortunate story is that despite all these advances in medicine, the impact of that on cancers, particularly cancer of the gallbladder and cancer of the bile duct and cancer of the pancreas, has been very slow, and we still are treating disease with surgery and non-specific chemotherapy, which are more or less modest methods in the treatment, because the results that we get are still not the best. The disease is quite aggressive, and usually it presents when the patient have symptoms and the disease has been there for usually years. So when we give the patient, the majority, which is about 40%, will be inoperable. What has changed, though, is the fact that laparoscopic surgery now became very safe and commonly done for symptomatic gallbladder disease. Is that in about 3 in 1,000 cases, when we remove a gallbladder, we could find an incidental cancer. And these incidental cancers are more or less, usually they are in their early stages. Not all of them, but a significant proportion of them are in the early stages or in the stages where the disease is limited to the gallbladder with no lymph node or some metastases, where we can treat them aggressively with reasonably long-term, good long-term survival. So we warrant always an aggressive treatment if we think the disease is localized. Now, this disease is mostly disease of the elderly. A majority of patients are women more than the age of 65, and the reason that it is distributed like that is the fact that gallstone disease is more common in females, and when the gallstone disease has been there for a long time, usually decades, there is an ongoing inflammatory / infectious process in the gallbladder, and the basis of carcinogenesis is usually related to this chronic inflammatory reaction that will affect the mucosa of the gallbladder. Now, often people ask, why do some people get gallbladder cancer? What are the risk factors? We need to be clear about the risk factors. Now, majority of patients who have gallbladder cancer, they have cholelithasis, gallstones. So that's the most common risk factor. There is some condition which is called porcelain gallbladder. Usually this occurs in association with gallstones in elderly women, and you see on the picture on the CT scan, the wall of the gallbladder looks like an eggshell. So it's called porcelain. That's what we mean by porcelain gallbladder. Calcification of the wall of the gallbladder is a known risk factor. Primary sclerosing cholangitis, an autoimmune disease that's associated with inflammatory bowel disease, is a significant risk factor for gallbladder cancer and cholangiocarcinoma in addition to that. And also these patients will develop liver cirrhosis and liver cancers eventually. Choledochal cyst. Now, choledochal cyst is any congenital abnormal dilatation of the bile duct, part of it, and there are a variety of types of choledochal cyst. Hopefully we'll get the chance to explain them later on. Now these conditions are cystic dilatations of the wall of the gallbladder, and the problem usually is discovered in early childhood or an adolescent patient and need to be treated aggressively to prevent carcinogenesis and eventually the diagnosis of cancer. Polyps of the gallbladder are risk factors, but because the disease is rare, we are not certain about the exact relationship between polyps and gallbladder cancer. How gallbladder cancer develops, does it always arise from polyps, like colon cancer, or is it not? Probably not, and the carcinogenesis here is more or less like cancer of the stomach and cancer of the pancreas, where the inflammatory process will lead to carcinogenesis and neoplasia regardless of the formation of polyps. But when we find polyps, particularly those are larger than 1 centimeter, we get concerned about those because they can be early cancers. There is a high risk of gallbladder cancer in native Indian Americans, and the highest reported incidence is from Chile, where they have a lot of gallbladder cancer that happen in Aboriginal Indians. No one knows why that is, but there is ethnic distribution in the process. Now, as far as the pathology, it's going to be one of these routine cliches that you will learn, but in general, it's an adenocarcinoma, and that's 90% of the cases. There are cases of variety of other cancers, such as adenosquamous cancers, or carcinoid tumor of the gallbladder. Small cell cancer cases are reported. An important small variant of gallbladder cancer is the papillary carcinoma. Now, this one develops in the form of polyps, and it has a favorable prognosis. Often, particularly when the disease is limited to the gallbladder, often cholecystectomy is going to be a curative procedure. The spread of the disease, again, it's a cliche like any other cancer. The lymphovascular, the local invasion, which can invade the bile duct, gallbladder, or the portal vessels, or the duodenum, or the transverse colon, depending on the location of these organs in relationship to the gallbladder, which tend to vary a little between people. And also, we should be aware of the transcoelomic spread, where cancer cells will spread in the peritoneal cavity and can lead to peritoneal deposits, which are considered as distant metastases, and patients who have peritoneal metastases will be regarded as having advanced metastatic disease. Now, the basic of the staging system for any cancer is the TNM staging, and it's worthwhile to know at least the T part of the staging, and it runs from T1 to T4. Simply, T1 is disease in its early stages, and it's divided into 1A and 1B. 1A will be only invasion of the lamina propria. You could see to your right-hand side the layers of the gallbladder. The gallbladder wall is very thin, so invasion and progression of the cancer doesn't take much to erode into the wall of the gallbladder. 1B will be invading beyond the muscularis propria and going into the muscular wall of the gallbladder that appears in the red color in the picture. we will call it T2 if it invades the perimuscular connective tissue, and that's usually the cystic plate that separates the liver from the gallbladder, where the gallbladder is attached to the under surface of the liver right in this area, with no extension beyond the serosa or into the liver. So there's no liver invasion, no extension beyond the serosa if the cancer is located on the peritoneal surface of the gallbladder. So, because of the structure of the gallbladder, there are two parts in terms of its relationship to the peritoneal cavity. The cystic plate, where there is a loose areolar connective tissue separating the liver from the gallbladder, and at the same time keeps the gallbladder attached to the liver. So if the cancer arises on that side of the liver, T2 will be limited to the cystic plate without invading the actual liver tissue. And if the cancer is located on the serosal surface of the or the peritoneal, the open peritoneal cavity, then invasion of the serosa without extension into other organs. Now, T3, the tumor will penetrate the serosa into the peritoneal cavity on the peritoneal surface, or it will directly invade the liver on the cystic plate side of the tumor without invading other organs. Now, T4 is the mainly similar to cancer of the pancreas, so it's called T4 if it invades one of the branches of the portal vein or the main portal vein or the hepatic artery or the branch that supplies the right side of the liver. So any vascular invasion, it is regarded as T4, and also any invasion to surrounding structures, such as if it goes to the duodenum or the colon or the stomach. So in reality, majority of patients that we get are going to be mostly T3 with distant metastases or T4 with distant metastases or lymph node disease. And when we get the tumor at the stages of T1, the results are very good. T2 and T3, the results are mixed and usually depends on whether there is lymph node spread or not. If the disease is reached T4 with or without distant metastases, then it is advanced and usually incurable. So the basis of the TNM classification and staging system are not really different from a variety of other cancers, which means that you just need to have an idea about the TNM staging at least. Now the problem, how do we get the problem clinically? What do we get? We get patients who either presented with the primary symptoms, or they had their gallbladder for symptomatic gallstone disease, and then under the microscope there was cancer. So that's called the incidental cancers of the gallbladder, and as I said, they might appear in about 3 in 1,000 cases of laparoscopic cholecystectomy for what is clinically thought to be a gallstone disease, both clinically and radiologically. Which means that when we get someone with the gallstones and the ultrasound doesn't show more than gallstones, we assume that this is a symptomatic gallstone disease, but there is a chance that there could be a malignant process already happening. Now, if the disease is advanced, the most common presentation will be right upper quadrant pain, very non-specific. It could radiate to the shoulder or the back, and it could look mainly like biliary colic. If the disease is advanced, then you can give the systemic symptoms. And then, again, you need to learn that the systemic symptoms of cancer are more or less cliche and common to all cancers, which will be weight loss, fatigue, poor appetite, sweating. It could invade the liver and feels like a mass on clinical examination of the symptomatic patients. That usually is seen in advanced disease that has invaded the liver and made a significant large mass that could be felt clinically and detected radiologically. Now, if the disease advances more, it could invade the bile duct, and that will lead to obstructive jaundice. Invasion of the bile duct can be either direct invasion by the cancer or as a result of metastatic lymph nodes in the hepatoduodenal ligament. And these lymph nodes are called the periportal. Sometimes we refer to them as the portocaval. But anatomically, they are lymph nodes that run along the portal vein and the bile duct in the hepatoduodenal ligament, which is the free end of the lesser omentum that joins the stomach to the liver in your anatomy. So these patients will present with jaundice in these advanced situations. Now, if we suspected gallbladder cancer, or we know that histologically we are dealing with gallbladder cancer, then we go to the next step. And again, all this runs the same system. So we take adequate history from the patient, physical examination, and then we get the liver function test and tumor markers. And the first modality of imaging, then the ultrasound scan. And then we move on to more cross-sectional imaging, and we do a CT scan of the chest, abdomen, and pelvis. The most common site for metastases that we are looking for are the liver, the peritoneal cavity, and the lungs, and eventually could be bones. Now, PET scan, the role is a bit controversial, but we do it locally in every single patient. We've been doing that, and it does help to rule out distant metastases. And as we say, these metastases can be in the lungs or the liver or the peritoneal cavity. If we find that the disease is localized to the gallbladder, then we plan to do surgery for them. And the surgery will be extended cholecystectomy. They go through the preoperative assessment, and provide their functional status is good, then they will be offered radical surgical treatment. Now, it's important that for any case, when we prepare for surgery in gallbladder cancer, is that we have to keep in mind that we're dealing with almost half of the patients who will almost certainly have distant metastases and will not be suitable for surgical treatment. And also, it's very important to do a staging laparoscopy in addition to the imaging. And in doing that, we are ruling any peritoneal spread, and also we could assess the lymph node status of the hepatoduodenal ligament, and if there are any suspicious nodules in the peritoneum or the liver, we take biopsies from that and we wait for the definite results. Now, I have got a CT scan here, and as you see, there is a mass in the gallbladder, and in the contrast enhanced imaging, you will see these masses are enhancing on the IV contrast CT scan, and also on the ultrasound there will be some vascular flow into them, and that usually is the first thing that alerts us to cancer if the patient get the ultrasound before the CT scan. So they do have blood flow into them to differentiate them from large non-radiopaque stones and polps. Now we move on to the treatment. The only chance for these patients to have meaningful survival or cure is surgery. And surgery is curative in the early stages. Now, if the patient had one A stage and they had a cholecystectomy and it was T1A, then cholecystectomy will be sufficient. 1B, 2, and 3 stages, when there is no distant metastases, are these patients who will be offered radical or extended cholecystectomy. So again, I say that stage 1B, according to the TNM staging, 1B, stage 2, and some of the stage 3 selectively, they will be offered an extended surgical resection. What does that mean? That means if the patient had no operation, he didn't have their gallbladder laparoscopically recently, then we do an open operation, we assess the peritoneal cavity, ensure there are no distant metastases, and then we take the gallbladder and in mass with segment 4B and segment 5 of the liver. This is the liver tissue where the gallbladder is attached to the liver. So it's a partial hepatectomy and involves two segments of the liver. The reason we do that is not only direct invasion can occur from cancer of the gallbladder into the liver, but the fact that the venous drainage of the gallbladder goes into the hepatic parenchyma. And you will see that when we operate on the gallbladder, we expose the cystic artery and control that, ligate it, or put a clip or a hemolock on that as part of the operation, but there is no identifiable vein. You could have small veins along the cystic artery, but very often the drainage is directly from the gallbladder wall into the parenchyma of the liver, in particular to these two segments of the liver. That's why we do a partial hepatectomy along with cholecystectomy. We also go in and dissect the hepatoduodenal ligament, and we take all the lymphatic tissue and the lymph nodes along the hepatoduodenal ligament, including the cystic lymph node and the portocaval lymph nodes up to the celiac or the common hepatic artery, which usually have a sentinel lymph node sitting at the top of the neck of the pancreas and very close to it. Now, these patients, if they had a recent laparoscopic cholecystectomy, and that's how we found about their cancer, we do what we call port site excisions. So we have to go and excise all the port sites, and that will be excision in mass, including the skin, the subcutaneous tissues, the muscle, and the underlying layer of the peritoneum. It could end up in a defect, particularly in the where the umbilical incision is made, and sometimes we need to close that either with a mesh or with nylon interrupted permanent sutures. But these patients often will be offered adjuvant chemotherapy. Unfortunately, the role of chemotherapy and radiotherapy is not very clear because the cancer is rare, and there are little information from previous studies. But we employ the chemotherapy that get given to other cancers in the gastrointestinal tract in a variety in variant combinations, and we leave that decision to the medical oncologist to do. But the medications are usually gemcitabine, cisplatin, 5-fluorouracil, capecitabine, or oxaliplatin in various combinations. Again, radiotherapy, we find there is some benefit from radiation therapy in gallbladder cancer and cholangiocarcinoma, so some of these patients will get offered radiotherapy as well. Now, there will be a significant section of these patients who will not have radical treatment, and then we could offer them either palliative chemoradiotherapy, and that will be given to patients with advanced cancer who have a zero functional status and they are healthy and well. Other patients, if they have quite advanced disease and they are elderly with multiple, particularly if they have multiple comorbidities, then you find that palliation is going to be the treatment, and that will be mainly controlling their symptoms. And if they are jaundiced by invasion of the bile ducts, we send the bile duct either by an ERCP or doing a PTC radiologically. In general, what will happen? Survival is for gallbladder cancer varies from 5 to 35%, and that is stage dependent, and that really takes every single patient into consideration. Now, we know if the disease is localized to the gallbladder, so as a general idea that I could give you is that if the disease is limited to the gallbladder, means that it is localized, no distant metastases, and no lymph node invasion, and we do extended cholecystectomy, we are looking at about 40% survival rate. But that would be a small subselected group of gallbladder cancer, which only amounts to about 20% of them. If the disease has gone to the lymph nodes, so there is local regional disease, then we're looking at a very modest 5-year survival, which is going to be more or less similar to pancreatic cancer, around 13 to 15%. Patients with distant metastases, the survival rate of 2 to 5 years is very small, and it could be somewhere between 0 and 3%. So in dividing the patients into early disease, localized to the gallbladder, or local regional, or distant metastases, it can give you an idea to manage the patients and also to communicate your treatment plan to the patient based on that ballpark figure or ballpark type of staging of the cancer into local, regional, and metastatic disease. I would love to hear from you, and I'm more than happy to answer your queries and questions. Leave me some comments, and thank you for staying with me for the video, and I will see you in the next recording. Thank you very much.